Hi, it's Andrea Russo. I'm from Cooper Hospital in Camden, New Jersey, and I'm joined here by my co-chair tonight, Rachel Lampert from Yale University School of Medicine in New Haven, Connecticut. And we're going to be talking about lessons learned and moving forward during the COVID-19 era. This symposium by HRS is supported by an unrestricted educational grant by Medi-Lynx Monitoring Company. Thank you for joining us tonight. Here are our disclosures. The severe acute respiratory syndrome coronavirus 2 emerged in Wuhan, China in late 2019. As you know, there's been very rapid worldwide spread. The pandemic was declared in March of this year with an estimated mortality rate of 1 to 5%. The pandemic has certainly challenged healthcare systems throughout the globe. You can see here now, there's over 20 million cases reported around the world. Unfortunately, many of them are in the United States, over 5 million. And you can see here how they're scattered throughout the world with this density shown here. Unfortunately, there have been 745,000 deaths so far. And this was just updated yesterday, but day by day, it's updated at Johns Hopkins. And unfortunately, more and more of the spread can be apparent. So there are lots of challenges with COVID-19 as you contagious. As you've already seen, there's this unprecedented global spread. It can sometimes have a very aggressive and serious clinical presentation. There's lack of any clearly effective treatment or a vaccine at this point in time. The goals of us during the pandemic are to care for COVID patients, and they can have a variety of different cardiovascular manifestations of disease shown here. But we also want to sustain care for non-COVID patients and protect our healthcare providers and other patients. So this has resulted in delivery of care that has been delayed for less urgent diseases. So for example, this was regarding surgery. So cardiac surgery and transplant services in Ireland between a short period of time comparing 2020 to 2019. And as you might imagine, there was a marked decrease. Operative activity fell by about 50%, and the acuity of the patients increased, meaning we're only doing surgery on sicker patients. And there's some procedures may be considered more elective, were not done at all during that period of time during the pandemic. Well, what about cardiovascular hospitalizations and outcomes? So this is an example from Italy. There were a reduction. This side here shows total admissions for acute MI during the crisis. So comparing 2020 to 2019. So in acute MI, there was almost a 50% reduction in admissions to the hospital for acute MI. And then if you look at the case fatality rate here on the right during acute MI, the mortality rate in the pandemic period of time was much higher than during the same time last year. So again, patients who are coming in, fewer patients are coming in, but when they come in, they are sicker. And so why might that be? Well, they may have a fear of hospitalization. Maybe they think that, they'll be more exposed to virus at that time. They may have concerns about the resources available in the hospital, or maybe they're just not referred in. They may be seen less often because they're not going to the outpatient provider and may be triaged less often to the hospital. So what about atrial fibrillation in the arrhythmia world? What about the incidence of atrial fibrillation? You could see here in 2019 compared to 2020. The blue bars will show you the total the onset of new occurrence, first diagnosed atrial fibrillation, and the red bars are hospitalization for new onset atrial fibrillation. This is in Denmark. The lockdown was declared at this point in time, and you could see here compared to 2019 that there was again almost a 50% drop in the total numbers of new occurrence of atrial fibrillation and hospitalization for atrial fibrillation. These other lines here look at the occurrence of ischemic stroke in the setting of atrial fibrillation or mortality in the setting of atrial fibrillation, and there was a trend towards an increase in those adverse outcomes in the setting of atrial fibrillation. So what do we need to consider during the pandemic? Well, we want to reduce contact between healthcare professionals and patients and most of this involves social distancing as well as masking. We want to preserve appropriate use of PPE. And due to resources needed for procedures, this will include personnel, including lab personnel, may include your anesthesia staff, ventilators, ICU, backup care, PPE. There's been a triage system constructed to help prioritize patients who are in need of more urgent care and identify those patients who might be more safely postponed. So the HRS, the Heart Rhythm Society, as well as the American College of Cardiology and the American Heart Association worked together to come up with a guidance document back in March. It was published online in March to look at which kinds of procedures might be postponed electively to still provide care to patients who might need more urgent procedures. And this was outlined here. So more urgent procedures or non-elective procedures may include, for example, things like VT ablation for electrical storm, things like lead revision for a malfunction of a pacemaker lead in a dependent patient, or perhaps an ICD lead a patient who's getting multiple inappropriate therapies for noise. Secondary prevention ICDs, again, fairly time-sensitive procedures. Although most SVT may be considered elective, patients who come in and out of the hospital, again, they'll increase exposure by coming to the emergency room over and over, and they're having a lot of symptoms. That may be considered sort of a semi-urgent procedure. Things that are more elective are things like a routine SVT ablation in a stable patient, CRT upgrade, CRT in stable patients, or things like appendage closure in patients who could be on oral anticoagulation for a while. In addition, we try to consider telehealth services, reducing face-to-face contact by utilizing telehealth and maximizing the use of remote monitoring for devices, implantable devices. So as electrophysiologists, we've been very fortunate to have this modality and remote monitoring available to our patients even far ahead of the pandemic. So we've been doing this for years. We've had guidance documents, published on how do we do a remote monitoring. There's a great outcome in real time, other than in COVID time, for performing remote monitoring. Can even decrease unnecessary therapy for ICD patients. It can increase, actually reduce mortality even in ICD patients. But in addition, we started to use capabilities related to video consulting. So even in the hospital, if you're seeing a COVID patient, to try to reduce the number of times physicians and allied professionals need to go in the room, preserving PPE, doing video consults whenever possible. So as you might imagine, and we've all seen, this is just some data from Duke looking at telehealth visits, telephone and video. Telehealth visits were up dramatically. We almost never did it at most centers, before COVID. And with the pandemic, you could see the great rise in telehealth. So what about reintroducing procedures and reintroducing office face-to-face visits? Well, one of the most important things is physical distancing. So in the office, your staff may have separated their seats by 6 feet, reducing the number of patients in the waiting room, maybe having patients wait out in the car and getting text when it's time for them to come in, minimizing the number of healthcare providers in contact with a patient, both in the hospital and in the outpatient setting, and minimizing visitors. For example, you may have no visitors coming with the patient to their outpatient visit. Same may be in the case in the hospital, even now as things are starting to recover in many regions. What about screening? Screening prior to coming in the hospital. I think many centers now, or perhaps most centers before doing procedures, will have COVID testing prior to the procedure. And again, appropriate utilization of PPE is really important in both the inpatient as well as in the outpatient setting. So what about the rebooting process? So once again, I have to say, during the pandemic, the collaboration between the societies has been truly amazing. So once again, the Heart Rhythm Society put together, along with the American Heart Association and the American College of Cardiology, a guidance document for how do you reboot these procedures. And so some factors you might consider is your capacity to provide care for non-COVID cases that are non-urgent. And that may really vary by region. region and local prevalence of the disease, your hospital and ICU census of all patients and COVID patients, your ventilator availability, PPE availability, your staff capability. In many places, the staff have been repurposed. Our lab staff may have been doing COVID testing. Physicians, including anesthesia, may have been repurposed to cover ICU patients. So you want to see a significant and sustained drop in local incidence. For example, here, you don't want this curve to keep rising, because then you're going to still have a lot of more patients with COVID that need care in the hospital. So you want to see the sustained decrease in incidence. But you may have certain governmental, state, local, or even hospital system policies in place that need to be followed. So there's regional variation. So how do you characterize different aspects that are important in rebooting? So what we did in this document was talk about the ability to perform elective procedures. And really that does depend on the prevalence and incidence of disease in your region. And even in the United States, that varies at different areas. So there's a high prevalence and high incidence in some locations still, medium prevalence and incidence, and low prevalence and incidence in some regions. So if you have a high prevalence and incidence, it's very limited number of elective cases are going to be done, and the opposite may be if it's a low prevalence now in your area. You want to consider the type of procedures, which I'll mention in just a second, PPE supply, and the testing of patients. And that's also variable. Some centers may have lots of testing capability, where other centers have very little testing for COVID capability. And what about the visitation? You need to decide what's appropriate. Is there no visitors under any circumstances, or just under extreme circumstances? Or are you really back in this green area where things are more normal? In the outpatient clinics, again, use of telemedicine. So how much should you use? Some patients may still be fearful of coming out and being exposed. So you may still mix and match telemedicine, whether your prevalence is medium or low, even after some recovery in your area. So what about the role of viral screening and testing? So the purpose is we want to limit patient and staff exposure. Again, there's a variability based on region in the availability of timely and accurate testing. You can test for the virus. So you can see here the viral RNA rise and then fall, but you can perform PCR testing to see if you have active virus. Serology testing, so IgE, may be indicative of a convalescent phase or post-infection phase. You want to look at your local and hospital testing policies. So typically, what many centers will do, and what we talked about in this document, is to perform PCR testing within 12 to 72 hours before the procedure. And then you tell your patients, don't go out in a crowd the next day, stay, and have some preoperative isolation until you have to reduce exposure. But no matter what you do for testing, you need to have mandatory symptom screening, temperature analysis, masking, and regardless of what else you're doing. So the list of EP procedures in the Reboot document and the workflow is really similar to what I showed you in the initial guidance document back in March that HRS led. But again, that depends on your local disease burden and how many of these semi-elective or elective procedures you'll be able to accommodate at your center. So what I'd like to do now is to turn over the webinar to my colleague, Dr. Lampert.
Thank you, Dr. Russo. So as you've described, COVID-19 has an impact on our cardiac patients, even beyond the impact of the virus itself, with fewer MIs presenting, worse outcomes, and excess deaths, even beyond what's expected for the virus. How the pandemic has impacted our arrhythmia patients, though, particularly those with atrial fibrillation, is harder to quantify. With atrial fibrillation, there are always many treatment options, and unlike with the myocardial infarction, the long-term sequelae of AF is often not immediately apparent. As Andrea noted in the earlier slide, investigators from Denmark described fewer new incidences of atrial fib, and then those patients doing worse. But how patients with known atrial fibrillation have been faring has not been described. New Hampshire, where I work, was amongst the earlier areas to see a surge of COVID-19 patients. Our state emergency was declared on March 10th, and we had a daily census of around 450 COVID patients, about a third of our total bed capacity, from early April until early May. Next slide. In conversations amongst our group, my group of EP colleagues, we found ourselves asking each other how we were managing our atrial fibrillation patients. We actually had an upcoming M&M conference scheduled, and we decided to use this forum for discussion. Since our procedures had been canceled as emergency measures, one of our fellows had time to look at our patients and see how things were going. So first, procedures that had already been scheduled and ended up having to be canceled. We had 29 previously scheduled AF ablations, 2 flutter ablations, 13 appendage closures, 8 cardioversions, and this was only amongst patients that had been previously scheduled, not even thinking about ones that had developed problems while the pandemic was ongoing. And so an informal survey of our group revealed a number of problems in how we were having to manage these patients. So we found many patients who were in need of cardioversion or ablation for AFib, and we were trying as hard as we could to manage them suboptimally with rhythm control. There were patients with flutter, same thing, having an even harder time managing them with rate control. There were patients in whom we normally would have brought them in the hospital for an inpatient medication load and cardioversion, sotalol, flecainide, which we generally load as inpatients, but we were trying to, again, manage them with rate control. Similarly, some of these patients, we ended up starting them on amiodarone, which we generally feel more comfortable starting as an outpatient. Let's go on to the next slide. So how did these patients do? And we found that they weren't doing all that well. So we looked at how we had modified the treatment plan as far as the ability to do elective procedures, and then how these patients were doing in 30-some of these patients. And we found basically a few patients who ended up being hospitalized anyway. Some of them just went into a spiral of heart failure and the other, as we see, and ended up in the hospital anyway. One person had a life-threatening GI bleed because his occlusion procedure had been canceled. Many of them had partial improvement in their symptoms, but many were just not feeling all that well. Next slide. So fortunately, like many of the earlier hit areas, people stayed home in Connecticut, and our surge started going down. And we were able to start elective procedures again towards the end of May. That brought up another problem, though. We were reassured by the hospital, who assured us that we should reassure our patients that coming in for medical care was safe. But how did we actually know this? It had been well described, as Andrea pointed out, in the lay, as well as in the lay press, that patients are foregoing care because they're scared of coming into the hospital. So although we had started doing elective procedures, we weren't yet back in the clinic, and I spent most of my telehealth clinics repeating the phrase, well, we don't know for sure, but we've instituted a lot of procedures to protect you against exposure, and it doesn't seem like it has a high risk. So we ended up looking at this question in our own patients. And the data are under review at Heart Rhythm O2 Journal, so I can't share the specifics, but we were very pleased to be able, after we actually looked at how our patients had been doing, those who had to undergo emergent procedures and had come into the EP lab, we are able to reassure our future patients that, in fact, even those patients at the height of our pandemic had done well as far as exposure. So while our measures were instituted locally from the get-go and were prior to or around the same time as the FHRS, the measures are similar. And so I think what our local experience suggests is that following the measures that are outlined in the document does in fact result in a safe environment. Next slide. There's very few, surprisingly few data out there that I could find on nosocomial infection in general, but from the data I've seen have been encouraging that by taking appropriate precautions, nosocomial infection rates can be controlled. This was a fairly small study in Hong Kong, but they compared their experience with the current coronavirus pandemic with their experience with the original SARS pandemic 17 years ago, when people were completely unprepared, and they found that that having incidents from there based on their experience in 2003, that they also had kept nosocomial transmission down. Next slide. So switching gears, like a lot of you, we found ourselves expanding use of remote monitoring both for standard purposes as well as some new ones. So I'm going to talk about both what we did with monitoring as far as our patients with arrhythmias, our regular EP patients, and then also what we found ourselves doing with the COVID-19 patients. Next slide. So the use of handheld monitors, handheld EKG recorders for arrhythmia patients is not new. I have to say, though, my use of these devices had been pretty limited. I was a little bit concerned in the past to sort of give our patients the ability to sort of check themselves whenever they want. I was a little bit concerned that it might lead to patients getting overly focused on their symptoms. But I have to say it really did become an extremely important part of patient care. So this is one of the patients I had described in the prior list. And as you can see, we're not really doing all that well with the rate control. Here he's feeling very winded. He took his vitals, and here's his alive core, and his AF's going like 180 beats a minute. So this is one of the people that we were only doing so. Next slide. So to talk a little bit about monitoring for inpatients, the FDA had issued an announcement actually only in late April, pro-arrhythmic effects of some of the medications that were being used for a good for a number of weeks at the beginning of the pandemic, specifically hydroxychloroquine, which everyone is very well familiar with from the lay press, and particularly if used in conjunction with azithromycin, which was also being used at the time. This was well known to the EP community, I think, a long time before the FDA actually acted on it. Mayo Clinic, lots of other people were putting out warnings really to say you have to be careful with this. Next slide. So we had instituted a monitoring algorithm really from day one that involved EKGs, telemetry. But one of the things that we learned, and you were going to check the QTC this often, and start it here, don't start it there, and if it changed, etc. But as we were working with our hospitalists and our operations teams as part of the COVID response, we were quite perturbed to learn that next slide. That there was a lack of telemetry in our hospital, both for COVID patients and also for non-COVID patients, because everyone was completely disrupted. So our COVID patients, back when we had, a census, basically a third to a half of our total beds, they had taken over several of the cancer floors because they had negative pressure rooms, which everyone thought would be very good. The problem is this whole wing of the hospital was not set up for telemetry because it was for oncology. So some of our sickest COVID patients were not on tele. And then similarly, other areas that had been taken over for COVID had displaced patients that really would have been on telemetry, like dialysis patients, to places that didn't have telemetry. So really it was really a very bad situation when we realized how disrupted our ability to deliver telemetry had been. So around the same time, we had been in communication with one of the companies, Medi-Lynx, that is sponsoring this, about pursuing COVID-related projects. And so this sort of seemed like a godsend that we might be able to use to solve the problem that we had in front of us. So we set up a plan to adapt the mobile cardiac outpatient telemetry units, both Medi-Lynx as well as other companies, for use for our inpatients who were being treated on floors without telemetry. Next slide. So we had to set up a monitoring hub. Our hospital has never had dedicated monitor watchers, so we didn't really have a centralized process for sort of getting the data back from the MCOTs and then transmitting it to the people that needed it, the on the floor caregiving teams. So the adaptation ended up being somewhat work intensive, partially because of the way we were set up. So everybody got into very high gear. It was a wonderful team effort. There were a lot of nurses who weren't able to work on the floor for various reasons, but had capabilities for watching and rhythm recognition. And so we were able to set up this monitoring hub with 24/7 coverage. We had shifts. Every shift had RNs and Holter technologists and a supervising advanced practice practitioner. who then served to be a hub that would get the information sent to us from the MCOTs, make a decision, confirm that they thought the rhythm was what it was reported to be, make a decision about the clinical relevance and the urgency. Sometimes they would check with myself or another one of the EPs, and then transmit that information to the physicians and the nurses on the floor. Next slide. So we found that these systems that we put in place were well worth it. We found amongst COVID-19 patients, of the 42, we found 16 with at least one critical event. We had some with ventricular tachycardia. We had several developing rapid atrial fib. And then we found 7 who had a QT prolongation that we were then able to work with the teams. At that time, we didn't want to stop the patient's HCQ because, we didn't know at that time that it was kind of useless. But so at that time, we would work with the teams to identify other factors. Are they on other QT prolonging medications? Are they have electrolytes out of whack? Are there other things we can do? So we really had a lot of actionable notifications that really contributed to the clinical care of these patients. Similarly, we also were monitoring non-COVID patients who, again, had been displaced to areas where they shouldn't have been because we didn't have room in other places. And again, we saw a lot of patients who had at least one critical event. Many of them had either sustained or non-sustained VT. Again, we saw pauses. We had a couple with AV block and rapid atrial fib. And so, just all the usual types of arrhythmias that we need to act on. And that's why these patients were scheduled to be on a telemetry floor anyway. So next slide. Northwell Health in New York City was among the earliest and heaviest hit hospital systems. And they did a similar plan as well, and they've reported on their much larger experience using their MCOTs. They were really using it predominantly for the QT monitoring, but they also use it for arrhythmias and similarly found a lot of actionable rhythms. So they felt as well that this contributed to patient care. Next slide. So while HCQ is no longer in the lineup for treatment of COVID-19 patients, and so the QT monitoring in that particular area may be less of a concern, we found that the adaptability for inpatient use of these MCOTs may still be an important option to be aware of. Our hospital, as I said, has the COVID-19 census has dropped at least for now, and things are returning somewhat to normal. However, in many other parts of the country, numbers are still increasing, and we're still reading about hospitals being overrun. We're hearing about tent hospital people being in tents. And we found this novel solution met our needs in the pandemic. We actually had set up in New Haven that the university gym might turn out to be a field hospital, but we never did need to use it. But that would be another situation where this type of monitoring would be very helpful. Andrea, I'll turn it back to you to talk about some of the other lessons we've learned from monitoring during the pandemic.
Great. Thank you, Rachel, for sharing, also for sharing your data and really highlighting, I think, adaptability and teamwork, the importance during this time. And to highlight teamwork, I have to say once again, what struck me is the collaboration and the importance of collaboration, this time on the scale of maximizing, health, telehealth and mobile health telemetry technology. And this was a HRS led this multi-societal document, the Hardy era. APHRS, LAHRS, ACC, and AHA got together to talk about, telehealth and, during and what's next. We all know telehealth is here to stay. Mobile health technology is certainly here to stay and only increase. So we learned a bit during the COVID pandemic now that there's certainly an arrhythmic risk in patients hospitalized with COVID-19, somewhere between 7 and 16.7%, depending on what study you look at. And in ICU patients, the occurrence of arrhythmias may be even much more frequent, but we have much more to learn in this regard. Now, patients who are hospitalized with COVID-19 can have just pre-existing arrhythmias. They may have prior infarct or other myopathy. They may develop new arrhythmias, or they may be placed at increased risk of arrhythmias by therapies that were used for COVID-19, as Rachel certainly alluded to and showed you some nice strips. So once again, there was a collaboration when this was a really, a high point of the event where people were being placed on, usually it was hydrochloroquine and azithromycin, combined. You could see both of these drugs separately have a known risk of QT prolongation and torsade. But here we were more concerned because some of these patients potentially could be outpatients, and we were concerned as a society group. So put out this statement for considerations and as a heads up to anyone thinking of that. So we do have lots of different ways to monitor, and our monitoring document talks a little bit about the device availability. Lots, and these are some examples of handheld devices, mobile telemetry devices. One like Rachel utilized, that's a real-time streaming, beat-to-beat streaming, so you see every single beat come across, and then smartwatches. So lots of different technology. We all see patients in the office bringing some of this, consumer device technology to us. So what about, use of this technology? But fortunately, the FDA put out this guidance for industry and use during the public health emergency, stated that you can use these non-invasive monitoring devices to help eliminate or reduce unnecessary patient contact and reduce the burden on healthcare systems during this public health emergency due to COVID-19. And so this applies to things like the wearable devices and handheld devices, as well as some of the mobile telemetry interfaces. And so the way they word it is limited modifications to the indications that the FDA already gave to the device or the functionality of the device to support this effort. And as you know, this information can be transmitted to a processing center and then sent back to the physician. So you can look at things like arrhythmias or QT monitoring. So how good is it? Well, we do have some limited data. I suspect we'll be seeing more and more of this as time goes on in the literature now. We have some information on wearable remote technology and just talking about QT prolongation, because that's what was really a concern early on in the pandemic with the investigational treatment. This was using a different wearable device. This looks like this, and comparing it to a 12-lead recording. And this was this is all pre-COVID, but done in long QT patients as well as in healthy controls. And you could see here, if you can compare what the device gives you and what the monitor gives you, you could see that it does reliably identify patients who have a long QT interval in this particular study. Again, still relatively small studies, but you could see here, this was another study. This one's with a handheld device, and this is looking at a smartphone monitor in measuring the accuracy and measuring the QT interval corrected, and a 12-lead ECG in healthy volunteers. You could see here again that there does seem to be good ability to predict using comparing it to 12-lead EKG, what you get on the monitor. So, and this also was useful, and there's different leads you could use with this particular technology, but lead one of this particular smartphone did tend to be a little bit better than lead two in predicting this QT prolongation. So there's some data. We need, again, more data to maybe extrapolate it further to other areas outside the pandemic and outside of what's already been published. So, what lessons have we learned, and what's the future here? Well, there's lots and lots of future to monitoring, and it's just a really, really digital health in general is just a really exciting field. But we know, as Rachel showed us very clearly with experience at her center, that this mobile telemetry can be adapted for inpatient use, resulting in effective monitoring of arrhythmias and corrected QT interval here. Currently available remote monitoring devices, and there are many, but including some wearable handheld devices, received this emergency approval by the FDA for supporting monitoring during the public health emergency. Obviously, this is a time-limited period that's still ongoing, but we can't. It did provide enhanced reach to patients who wouldn't have been seen or monitored perhaps at all, and could have been at more risk and danger, as well as allowing continued access to care for them. And we do have lessons learned during the pandemic, but how can we extend it beyond the pandemic? And that's, I'm sure we'll be hearing more and more about. But our other thing we've seen too is that we've been able to keep patients out of the hospital. Again, utilizing some of this monitoring technology has really helped us in the electrophysiology world during COVID. And this was really considered a matter of life and death, right? Before we knew that we can successfully protect our patients and protect our healthcare providers with using appropriate PPE and taking other precautions. But shouldn't we always be considering doing this, right? We know it's costly to come in the hospital, but isn't it the best way? I think more and more of us in electrophysiology have been really leaning on remote monitoring, event monitoring, mobile telemetry, and even the consumer devices to really help keep people out of the hospital. That can only help with patient satisfaction, certainly patient convenience, as well as potential implications for cost containment. So I thank you. I thank you for joining us. And so we'd like to now open this for a Q&A period of time. So please go ahead and feel free to send some of your questions in through the chat.
So I have a question that came through. Can you hear me?
Yes.
Yes.
So were you able to monitor patients using remote monitoring on non-telemetry units effectively? I think that was referring to something maybe Dr. Lampert had asked or was talking about.
Yes, I think we were effective at getting that system going. So is it as good as telemetry where you see the monitor right in front of you and the nurse is right there and the patient's right there? I would say no. But so if you have telemetry, I wouldn't replace it with the use of an MCOT. But if you're in a situation where you don't have telemetry, I think what we found was that the use of these adapted systems really were extremely effective. We picked up actionable arrhythmias and acted on them, and we were able to monitor the QT, which is was particularly relevant at the time of hydroxychloroquine use, but it's something that we're always paying attention to as electrophysiologists. And so I would say yes, we really did find this an effective approach.
Okay, the next question: what do you currently recommend regarding following ECGs in patients on antiarrhythmic drugs during this pandemic?
I can comment on that. It all depends, first of all, on where you're at in the pandemic. So what your regional prevalence and incidence is. So if you're almost back to normal and you have very low prevalence and incidence, I'd say, monitor right now during your routine ways that would normally. So depending on the drug. So if it's a really, QT prolonging drug, something like difetilide, I think right now I would still bring them into the office to get a 12-lead EKG, but knowing if the patient can't come out or if they're afraid to come out, that I would utilize other monitoring. And I usually will use a variety of different things. Sometimes you could use something just like a Holter monitor. You can send out a monitor. We have some of the companies will mail out the monitor, send the patient a mailer, and it's they're disposable units, and then you mail it back. So for just measuring a QT interval, a 24-hour Holter monitor in a patient who can't come out, and we utilized it actually quite often during the pandemic when we were a high prevalence region. So I would not be concerned about that. I also have utilized, I have a lot of patients even before the pandemic who utilize either their smartphone, they're coupled with a watch or other technology that they may have at home, consumer devices, and they'll send their strips. They'll email them. They'll send them into us, and we will respond to that. So I'd say right now, standard. You use your standard for some of the really more serious drugs that might prolong the QT, particularly if patients might be adding drugs or if they might have had some change in their renal function and drug that's renally excreted, still bring them in to do a 12-lead EKG. But if you're concerned about having the patient coming out, if you're in a high area of prevalence, using some of this either smartphone or some of this other technology would be acceptable.
Can I jump in there too?
Yeah.
I think in thinking about a couple of different types of patients, for me, if it's the type of situation where I would have had them at home getting the medication, but going in to get a 12-lead EKG. So, for example, someone being with a risk factor for QT prolongation, maybe being started on an antidepressant. That's someone I wouldn't bring in the hospital to start the antidepressant. I'd have them getting EKGs, at a lab. So for someone like that, I did sort of move towards using the handheld QT. So they would record their handheld EKG, send it to me. I'd check the QT, and obviously if there are any questions, then I'd make them go to the lab. But I did find that for that type of patient that you're only doing the intermittent EKG anyway, that the handheld worked really well. But I think there's a really interesting question that I think we really need more research on, which is there's the patients that we just have right now, we bring in because they need continuous telemetry. So the patient getting started on dofetilide, being the obvious example. And I think really an intriguing question is whether we will be able, now that these monitors are all refining their ability to measure QT, that may be a group that we need to do some research on to see, can we load them safely at home using these devices, many of which now have automated QT measurement. And I think that's an exciting avenue for the future that may save patients hospital admissions down the road.
I agree totally. And I actually think that's an important part. So actually, I have been using, even before the pandemic, for other drugs like flecainide. I don't bring either doing intermittent or more continuous monitoring at home for just for potential effects on bradycardia. So I'll give them a mobile telemetry monitor if I'm a little concerned, but not overly concerned to hospitalize. But I agree with you. There's some data on subtle, in normal hearts and without a lot of other, baseline abnormalities. But I think without further research, I certainly wouldn't do it for dofetilide at this point.
So the next question is, did any of your patients on telemetry surveillance have issues from the administration of hydroxychloroquine? Would like both opinions.
So we kept track of that, both for our telemetry patients, and actually before we started the MCOT thing, we were had a very sort of proactive plan where we as EP were getting shunted all of the COVID EKGs and working with the teams to try to figure out ways to ameliorate any QT prolongation. And we saw a fair amount of QT prolongation. This data actually came out, one of our fellows, Dr. Jane, this came out in Heart Rhythm a month or so ago. We found a lot of QT prolongation, but we did not see a lot of torsade, and that actually has been published by others as well. Point, I think it's mostly, as I say, out of the lineup, but I think that was our experience.
Yeah, so obviously we had a very, and I think we're talking at two centers that have a very detailed protocol. So we had your protocol you showed, ours was probably a little simpler, but certainly if you start to see significant prolongation, I think my concern is more, some centers may not have a protocol in place, or people are starting these things at home, is a different story. So I think we probably will be seeing less of the torsade because we stop the drug if the QT gets too long in that situation. But we do see, and I don't know, even without using those drugs anymore, on the monitors, we may see some non-sustained VT. You may see, some atrial arrhythmias in these patients. And the question is, is there a little bit of, underlying myocarditis or something else going on? Or is there some pre-existing, disease in there? And I think we don't know a lot of that. And we're going to really need to really find that out, down the line. But certainly we did not see any sustained arrhythmias once we started that protocol to monitor.
And this question might play right into that, because is there any special monitoring we should consider after hospital discharge in patients who were COVID positive without any known prior heart disease, And should we be screening for arrhythmias in the outpatient setting, even if they are not on QT prolonging drugs anymore?
That is a great question. At this time, so little is known about the long-term sequelae of COVID. Like, we don't even know how many people had myocarditis at the time, let alone how it's going to affect them down the road. So there's so much we don't know. But that's another, I think, really important question for future research, something we've talked about. I think others as well are starting to look into doing some monitoring, particularly if you're actively looking for myocardial disease in inpatients, so checking troponins, what have you. Certainly, I think it would be very interesting to start to learn in a systematized fashion, particularly if someone has shown some indication of myocardial involvement, such as troponin leak, whether they do have longer-term arrhythmic type sequelae. And I think that is an important research plan involving longer-term monitoring.
Yeah, and I agree with that. Yeah, Rachel's statements, yeah, completely. We don't know. We need to learn, and we need to research that area.
So another question: should routine device checks be seen in an office setting or still be seen remotely during the COVID reboot period?
You know, it's an interesting question. You know, I think there's no right or wrong answer. One of the things, and I think we thought about this a lot more during COVID, is, you know, we bring patients to the office and we put this monitor, this wand over the patient, and obviously that may have had contact with other things. So we're cleaning, you know, very vigorously in between every patient. We clean the wand, we clean the program, anything that touches the patient, we try to make it clean, even though the mode of transmission, you know, may be less likely from foam, but less likely from objects than it is from, you know, aerosolized. But so we don't know the answer to that. I think if you do it, you need to pay particular attention in the office to making sure everyone's safe. You know, masking, certainly if the patient, they could be asymptomatic, or if they're coughing, they could certainly, when you get close to patients at any point in time. So I think utilizing PPE appropriately, masking, and cleaning the programmer. I think more and more of us are thinking, and someone brought up the other day, we're talking about, you know, remote monitoring of patients, and some people, even though we're back in the office, we're not doing this, we're actually doing interrogations, but are doing the interrogation that morning before they come to the office, and then doing their regular clinical visit at the time. So I'm curious to know what Rachel's doing too.
That's exactly what we're doing, that kind of hybrid model. We're at a point where our patients are being given the choice. Do you want to come into the office for an in-person visit? Do you want video? And over the past couple, probably month or two, more and more are wanting to come into the office. As I say, things are pretty quiet in our state, and so people are feeling like they want to see their doctor, they want to be in the room with their doctor. But for all those reasons, basically our clinics are working very hard just to streamline things. And so the clinic basically didn't want us moving the machine in and out. We'd have to clean it, and it was just going to be that much more sort of stuff going on. And so we do exactly that. Basically, we ask our patients to send an extra remote in the morning so that we kind of can give them an up-to-the-minute report on how things are going. But we very, very rarely, every once in a while, someone comes in, they didn't get the message, you know, and then we will just do the in-person interrogation, but for the most part, we're doing that plan where we have them do the transmission in the morning.
Okay, so next question. Are you seeing increased arrhythmia or increased endocarditis with COVID positive patients in your clinic?
Yeah, and that's actually, you know, a really important question. There was the Heart Rhythm Society also put together a questionnaire to see how often we were seeing arrhythmias in general. And the hard thing to know is, you know, first of all, is how many patients we're really seeing that have hit. We know certain patients have been exposed to COVID, have been COVID positive. I think there's so many more people out there that are not. And for the most part, the minority of patients that I've seen in the outpatient setting have been COVID positives. The inpatient side, though, it's variable. And I think some of these patients have had pre-existing cardiac disease, and they do come in, whether it's related to the virus or related to myocarditis related to that, or just related to increased stress, or just medication, adherence at the time if they couldn't get out and get medicine. It's not really clear. So there are some patients who have had increased arrhythmias or pre-existing arrhythmias. Do I think it's from COVID or not? I really have no idea. I don't know the answer to that for sure. But we need to learn more about that.
I would just echo too. Certainly, we know that at times of major population stress, even aside from all the actual impact of the medical impacts of the virus, times of increased population stress, we see higher numbers of ICD shocks. Excuse me. So, for example, after 9/11. Even in Florida, there were two papers about increased ventricular arrhythmias after 9/11. One came from New York, where 9/11 happened, but another one came from Florida. And even in Florida, people just from the stress. And I think, the pandemic is really probably a greater stress than 9/11. 9/11 was terrible when it happened, but then it sort of passed. Whereas it wasn't like every single person had to shelter in place the way things are going with the pandemic. And so, I think it's quite likely. I think some of the companies are working with some investigators to look at that, whether we are going to see an increase in ventricular arrhythmias related to the pandemic.
So do you take any special precautions for patients with devices being interrogated in the office setting?
I think other than it's a good question that brought more awareness to it, but we do clean the programmer head. We do, clean clean anything that contacts one patient to the next patient. So some people put a sleeve on it, if they're, or something wrapping plastic around the wand is what we do. I think it's, it's interesting that, so the whole pandemic, all this, it's all so new to all of us. And I think as we, when the Heart Rhythm Society also put together this COVID-19 task force, I have to say, I certainly learned so much. I mean, I was a microbiology major undergrad, and I just brought back all this infectious disease work, and it really is intellectually stimulating, because there's so much more we need to learn. And then what about the recovery? What about years down the line, if people have had COVID infection? Is this just something early on? If you get some inflammatory responses, will you see it immediately? How do you measure it? What is the long-term consequences down the line? I think there's so much that we need to learn. We'll learn over the years.
And then another question is, during video visits, are you prescribing remote monitoring?
Yeah, so certainly sometimes. Video visits, I miss being in the room with patients, because I think there is a connection that you make when you're in the room. But I would say for the most part, we can do a lot on video visits. So certainly anybody with symptoms, you're seeing a new patient with palpitations, you're going to order monitoring the same way you would. We certainly get reassurances from all the monitor companies, that they're sterilizing their equipment in between patients and that kind of thing. So there is no reason not to order a long-term monitor for somebody with palpitations or syncope or AF burden, or any of the reasons that you might have ordered a monitor before. And so I'm certainly doing plenty of that on our video visits.
Interesting. So we even learned we could do wound checks, right? Video visits, which really more than we're really surprising how much the adaptability and really because of the situation we needed to. But if patients are traveling 2.5 hours, they find it quite convenient not to have to pop up and a week or two later and do their wound check in the office. If we can do it remotely and through video, we will do it. So I think it's really opened our eyes, just the world of telehealth, the world of just enhancing what we're already doing in electrophysiology. Our impetus to increase digital health in general, I think, has just made us more and more aware. And I think the good news is all the data that we've had for years and years, that remote monitoring for devices, improves outcomes. It reduces inappropriate therapies. It increases lifespan. It reduces mortality. And I think even some people weren't putting pacemaker patients on remote monitoring, I think there's more and more of those patients. So I'd be interested to see, the increased uptake on data that we already knew was data we had out there with studies showing how great remote monitoring is. But now when it was a necessity, how much more adherent we are to it.
Okay, so last question. Are your hospitals and clinics anywhere near back to full capacity yet? And that's for both of you to answer.
I would say right now we're on the way. So our labs are doing elective procedures, and from our census, which I showed you earlier, was 450 for most of April and May, is now under 20. So from the perspective of our inpatient practice, I think it's pretty close to back to normal. There's still some patients who are choosing to postpone their procedures out of fear, which is, I think for the most part, as I said, from our own data, we can do these things safely, but I don't think it's completely unfounded that our older, sicker patients might want to just be at home. But for the most part, our inpatient practice is, I would say, pretty close to back to normal. Outpatient-wise, our clinics are getting there. The social distancing does create sort of a bit of a loss of efficiency. We can't see quite as many patients in an hour as we did previously. So I would say we're close. We're getting there. I wouldn't say we're back to normal quite.
Yeah, and I think that our experience is similar. Our inpatient procedure volume actually is very back to normal. In fact, initially, I think it might have even, you have all these backed up cases, and you can, a generator replacement is elective, but it's only elective for a certain amount of time. So some of these cases that you held off for a while, needed to come in. And so we had to, figure out how to do that. And I actually was surprised. I think patients are a lot more comfortable than I thought they would be with coming back to the hospital. And I just saw, actually, I think it just came out today, a little report on a short research letter showing that we must be doing something right, or at least in terms of healthcare providers thinking we'd probably be the highest risk of being exposed, but we're taking all these precautions. So I feel the safest when I'm in the hospital with all my garb and everything on. So maybe patients get the feeling that they do feel safe in that environment and are not so hesitant. Although I do have some for sure who want to just wait until this is all done for a very elective procedure, but certain procedures are not all that elective. So yeah, I think our experience is similar in the outpatient setting also, is there's only a certain number of patients you could see in that time.
One thing I would just point out, though, is both Andrea and myself we're from Connecticut and Pennsylvania. So we're from two states that were hit hard pretty early. And then we're able to sort of, flatten the curve, as that, everybody was saying. I think, though, other states are still seeing rises, Texas, Florida, some other states, Georgia. And so I think our experiences in the Northeast, I think, are maybe a testimony to what some of these public health measures can do. But I think our experience may not be generalizable right now to hospitals all across the United States. So.
Okay, so that was our last question.
Okay, so maybe Rachel, do you want to close up a little bit?
So thank you. It's been such a pleasure for Andrea and myself to be here this evening. CME and CE can be found on the FHRS 65 website, and that's actually up to the next 12 months. And so I'd like to end by just thanking Medi-Lynx again, as well as thanking the Heart Rhythm Society for sponsoring and hosting this webinar. And I hope everyone enjoys the rest of your evening. Thank you.
Thanks for joining.